I want you to start by just, closing your eyes for a second. Just recall a universally frustrating physical sensation.
Oh, yeah. We definitely all have one of those.
Right. So you are going about your day, you're highly focused on some important task, and suddenly you feel it. A single loose eyelash has fallen and gotten trapped right there on the surface of your eye.
Yeah.
The disruption is just instantaneous.
It really is. It demands this immediate neurological override. Like, you can't focus on an email, you can't carry on a conversation.
No, not at all.
The brain just shifts all of its processing power to that single microscopic point of irritation.
Right, because the pain response is wildly disproportionate to the actual physical object. I mean, you get that sharp stinging, your lacrimal glands go into overdrive, and you're immediately running to a mirror to fish this nearly invisible thing out.
Yeah, it's a nearly invisible keratin fiber, but it feels like a boulder. We've all experienced that acute, agonizing annoyance.
We totally have. But take that memory and try to visualize a scenario where that eyelash is not just a loose hair that drifted onto the globe of your eye. Yeah. Visualize that eyelash firmly rooted in its natural follicle, but it is actively growing backward.
So it's locked into the anatomy rather than just, floating on the tear.
Anchored, completely anchored. So every single time you blink, which we do thousands of times a day, that hair is physically dragging and scraping directly across the corneal epithelium.
Oh, wow. That sounds terrible.
It doesn't wash out. It doesn't migrate to the corner of your eye. It just relentlessly strikes the surface.
The mechanical reality of that is genuinely brutal when you map it out. I mean, we're talking about thousands of microscopic abrasive strikes every single day.
And that biological glitch is the foundation of our deep dive today. We are looking at a clinical overview compiled by Dr. Avijit Bandyopadhyay of Disha Eye Hospitals. And it details a condition known as trichiasis.
Right, trichiasis.
What is immediately compelling about this text is the juxtaposition. Like, the text uses this very measured, objective clinical terminology to describe what is essentially an escalating physiological nightmare for the patient.
Yeah, the clinical detachment in the text really serves to highlight the sheer mechanical precision of both the disease and the cure.
Exactly.
It maps out a breakdown in the fundamental engineering of the human eye. We are looking at a system that relies on sub-millimeter tolerances.
And when those tolerances fail, things go bad quickly.
They really do. The interventions move rapidly from targeted chemical destruction to complex architectural reconstruction, and eventually, as we'll see, into the realm of global epidemiology.
Let's start with that fundamental engineering breakdown, because the defining characteristic of trichiasis, as outlined here, is the misdirection of the eyelashes. The follicle orientation just reverses.
Right, they grow inward instead of outward.
Exactly. And to understand why this is so devastating, we have to look at the surface it's interacting with. The text points directly to the mechanical injury against the sensitive corneal surface.
The cornea's innervation density is really the key factor here.
It's the nerve endings, right?
Yeah, exactly. We are dealing with tissue that has an incredibly high concentration of nociceptors, which are pain receptors. It's far denser than anywhere on the epidermis, like your skin.
Oh.
And the evolutionary logic is clear, right? The cornea must trigger a massive, immediate blink reflex at the slightest atmospheric anomaly to protect your vision.
Makes sense. Dust hits the eye, you blink instantly.
Exactly. But the issue with trichiasis is that this hypersensitive alarm system is being triggered internally. The threat isn't environmental dust. The threat is the eyelid itself.
And the structure of an eyelash, I mean, it's remarkably rigid. It's designed to be a physical barrier, sweeping debris outward.
Right, it's a stiff little fiber.
So when you turn that rigid fiber inward against that dense network of pain receptors, the text describes a highly specific cascade of symptoms. It initiates with a, quote, foreign body sensation and progresses to reflex watering.
Which is a totally natural reaction.
It is, but the biology of that reflex watering actually seems counterproductive in this specific scenario.
Yeah, it completely backfires. It creates a feedback loop of irritation because the lacrimal reflex, the tearing up, is an osmotic and physical flushing mechanism.
The brain is trying to wash away the invader.
Right. The brain detects the abrasive strike, assumes it's a foreign particulate, and floods the ocular surface to wash it away. But because the eyelash is anchored in the eyelid margin, the tear film doesn't wash anything away.
It just sits there.
Worse, it alters the surface tension and lubrication dynamics. This often causes the patient to blink even more frequently to clear the excess fluid.
Oh, man. So you blink more, which means more scraping,
Exactly. Every compensatory blink accelerates the mechanical damage.
which pushes the pathology into the next phase outlined in the text, which is superficial corneal erosion. The friction is literally sloughing off the outermost layers of the cornea faster than they can regenerate.
It's basically a process of physical wear and tear. You are dragging a biological wire brush across a highly specialized transparent membrane.
A wire brush on your eye. That is an awful image.
It is, but it's accurate. And once that epithelial layer is compromised, you lose the primary barrier against pathogens, which sets the stage for the final, most severe outcome the text warns about: full-blown corneal ulceration.
And a corneal ulcer means the erosion is penetrated deep into the stromal layer, right?
Yes, the actual structural integrity of the cornea is breached at that point.
And what does that do to the eye?
Well, an ulceration in the stroma triggers an aggressive inflammatory cascade. White blood cells, leukocytes, flood the area, which causes opacification.
Meaning the cornea gets cloudy.
Right. The collagen fibrils in the cornea are usually perfectly aligned, which makes them transparent. But the inflammation ruins that alignment. The patient experiences photophobia, excruciating pain, and ultimately permanent scarring that obscures their vision.
So this isn't just discomfort we're talking about. It is a mechanical pathway to blindness.
Exactly. It's progressive structural failure.
Okay, let's unpack this a bit, because the mechanical failure here reminds me of a catastrophic failure in, say, an automotive assembly, specifically the windshield wipers.
Oh, that's a great analogy.
Yeah, the system is designed with a rubber blade to clear a delicate glass surface. Trichiasis is basically the equivalent of the rubber wearing away, leaving the exposed, rigid metal wiper arm dragging directly against the glass.
Right. And you wouldn't just keep running the wipers like that.
Exactly, because every swipe gouges a new channel into the windshield until the driver loses all visibility.
And just as a gouged windshield scatters light unpredictably, the scarred stroma of an ulcerated cornea destroys the optical clarity required for image resolution on the retina.
It just ruins the optics entirely. Now, right at the onset of diagnosing this mechanical failure, the text explicitly mandates something called a differential diagnosis. The clinician has to distinguish trichiasis from distichiasis.
Which is a crucial distinction.
Right, because at first glance, they both involve eyelashes rubbing against the eye. But the anatomical origin is radically different, isn't it?
Completely different. The distinction dictates the entire surgical approach later on. We aren't just looking at the trajectory of the hair, we are looking at the specific biological origin of the follicle itself.
The text notes that distichiasis is characterized by an accessory row of soft lashes growing in or along the meibomian orifices.
Yeah, the meibomian glands. They are a crucial part of the ocular surface ecosystem.
What exactly do they do?
They are sebaceous glands, basically oil glands, aligned right along the margin of your eyelids. They secrete meibum, which is a lipid-rich oil that coats the tear film to prevent your tears from evaporating too quickly.
Oh, okay.
Yeah.
With distichiasis, we aren't dealing with a normal eyelash that has physically rotated inward. We are looking at a completely abnormal secondary row of lashes emerging directly from the oil glands themselves.
Precisely. You have the primary lash line, which is totally normal, and then this rogue secondary line emerging from the meibomian orifices.
That's bizarre. How does that happen?
The text points out that this can actually be a congenital anomaly, meaning you're born with it. During embryonic development, the cells that are supposed to turn into oil glands take a misstep in their cellular programming.
They just get confused.
Essentially, yeah, they differentiate into hair follicles instead of sebaceous glands.
But the text also highlights that distichiasis can be acquired later in life. It points to, quote, significant inflammation in the lid structures as the trigger.
This is a fascinating demonstration of cellular metaplasia.
Metaplasia, what does that mean in this context?
It means that when the meibomian glands are subjected to chronic, intense inflammation, the prolonged stress essentially forces the cells to alter their phenotype. They adapt to the hostile environment by changing what they do.
Wait, really?
Yeah. They stop producing oil and start producing keratin. The gland literally transforms into a functioning hair follicle.
That is wild. The body's response to chronic inflammation is to literally overwrite the cellular programming of the oil gland, turn it into a hair factory, which then grows inward and destroys the cornea.
It is a completely maladaptive response, and it really underscores why the clinician has to map the anatomy so carefully before treating it.
Because the treatments would be different.
Oh, totally. If a doctor assumes they are looking at trichiasis, a misdirected normal lash, but the patient actually has distichiasis, a lash growing out of an oil gland, any superficial treatment of the normal lash line is going to completely miss the hidden, deeper threat.
Because they're treating the wrong row of hairs entirely.
Exactly.
Okay, well, this mechanical mapping leads directly into the underlying etiologies or the causes. If the cornea is being shredded, and we know the lashes are the weapon, we have to look at the trigger causing the eyelid architecture to fail in the first place.
Right, we have to find out why the gun fired, so to speak.
The text outlines infection, inflammation, autoimmune conditions, and physical trauma like burns or specific eyelid injuries as the primary culprits of trichiasis.
The physical trauma etiology really provides the clearest mechanical model for how a normal follicle rotates inward.
Yeah, thermal or chemical burns seem obvious. When the skin layers suffer severe trauma, the healing process isn't exactly a perfect replication of the original tissue, is it?
No, not at all. It relies on collagen deposition to bridge the tissue gap as quickly as possible. But scar tissue lacks the complex, elastic architecture of healthy skin.
It's much tighter, right?
Right. As the new collagen matrix forms, it undergoes something called cicatricial contraction. The tissue physically shrinks and tightens as it matures.
So if you have a laceration or a burn near the edge of your eyelid, that scar contraction creates a pulling force.
A mechanical vector, yes.
As the scar shrinks, it exerts mechanical tension on the surrounding tissue. It physically torques the eyelash follicle out of its normal outward-facing alignment and drags it backward.
The force of the contraction just overcomes the natural structural support of the follicle. The hair doesn't change its growth pattern. The entire foundation it sits in is warped.
That structural warping makes complete sense for a sudden traumatic event like a localized burn. But Dr. Bandyopadhyay gives a massive amount of clinical weight to an infectious cause.
Yes, he does.
The text explicitly highlights trachoma as a leading cause. It notes its highly endemic nature in regions like Punjab, Bihar, Haryana, and Rajasthan. But how does an infection like trachoma cause a localized eyelash issue?
Well, trachoma pushes the discussion from isolated physical trauma into the realm of chronic population-level disease. We're dealing with an infection by a bacterium called Chlamydia trachomatis.
I was looking at how a bacterial infection bridges the gap to a structural eyelid failure, and the text actually provides the key in the differential diagnosis section. It lists cicatricial conjunctivitis alongside lid scars.
That's the missing link right there. The conjunctiva is the mucosal membrane lining the inner surface of your eyelids.
Okay, the inside part.
Yeah. And with trachoma, we are not looking at a single acute infection that just clears up. In hyperendemic areas, individuals, usually starting in early childhood, are subjected to repeated cyclical reinfections.
Over and over again.
Exactly. And each active infection triggers an intense inflammatory response in that inner lining.
Lymphocytes and macrophages flood the tissue to fight the bacteria.
Yes, and over years of these repeated inflammatory cycles, that mucosal tissue undergoes severe cicatrization. Scar tissue builds up all along the internal surface of the eyelid.
Which brings us back to the physics of scar contraction, but this time it's happening from the inside out.
Exactly. The interior lining of the eyelid begins to shrink. The mechanical tension created by this massive sheet of internal scar tissue pulls the entire lid margin inward.
Wow.
It's a progressive, highly destructive structural collapse caused by the body's prolonged immunological war with the bacteria.
And the text differentiates this localized follicle warping from broader architectural failures. Like, it lists lid entropion and epipopharin as associated problems that doctors must rule out.
Entropion is really the ultimate progression of that internal scarring we were just talking about.
How so?
In isolated trichiasis, you might have specific scarred follicles twisting inward while the overall edge of the eyelid stays stable.
Just a few rogue hairs.
Right. But in cicatricial entropion, the internal scarring is so extensive that it overcomes the structural rigidity of the entire eyelid. The whole margin just rolls inward against the eyeball.
Pressing the entire lash line against the cornea.
Yes. The vector force of the internal scar tissue literally curls the eyelid back on itself.
That sounds excruciating.
It is. Now contrast that with epipulveron, which the text also mentions. Epipulveron presents with eyelashes rubbing the eye, but the structural mechanism is completely different.
It's an anatomical anomaly, right?
Yeah. It's a redundant fold of skin and muscle near the eyelid margin that physically pushes the lashes inward.
So the follicle alignment is normal, and there's no internal scarring.
Correct.
Yeah.
The skin fold is just crowding the lashes against the globe.
So the clinician is standing there looking at a patient with a shredded cornea, and they have to reverse engineer the mechanical failure. Is a skin fold pushing the lashes? Is a massive internal scar curling the whole eyelid? Or did a localized inflammatory event just torque a few individual follicles?
Because if you don't map the specific forces causing the structural failure, your intervention will fail.
You can't just guess.
No. You cannot treat a congenital skin fold with the same surgical geometry you would use for a trachoma-scarred eyelid.
Which transitions us directly into the medical interventions outlined by Dr. Bandyopadhyay. Once the doctor has mapped the failure and diagnosed trichiasis, the immediate clinical mandate is halting that relentless mechanical friction before the corneal ulceration becomes permanent.
We have to stop the abrasive strikes.
And the text provides a fascinating, really escalating toolkit of tactical strikes against the follicle.
The progression of treatments here is really a study in precision tissue destruction.
But the text establishes a strict prerequisite before any of that follicle destruction occurs. It mandates treatment of the underlying cause first.
This is fundamental.
Like, if the etiology is active trachoma, it specifies the STAR protocol surgery for trichiasis, combined with antibiotics to prevent recurrence. Or, if the issue is a broad structural failure like entropion, the text dictates that the entropion must be surgically corrected first.
This is just basic surgical logic. You cannot isolate a microscopic variable if the macroarchitecture is completely unstable.
Right.
If the entire eyelid is rolled inward due to entropion, attempting to destroy individual eyelashes is clinically futile. You have to relieve the massive forces curling the lid before you address the residual bad follicles.
Fix the foundation before you fix the plumbing.
Exactly. And similarly with trachoma, if you don't eradicate the bacterial load with antibiotics, the ongoing inflammation will simply generate new scar tissue, creating new inward pulling forces and rendering any surgery totally useless.
Okay, assuming the macroarchitecture is stabilized, the text moves to the direct neutralization of the aberrant eyelashes. And the first method listed is mechanical epilation, which is basically just using forceps to manually pluck the hair from the follicle.
Very straightforward.
But the text attaches a pretty significant clinical caveat, noting that recurrence is anticipated every 3 to 4 weeks.
Yeah, mechanical epilation is the most primitive intervention. It provides instantaneous relief from the corneal friction, which is great, but it is biologically superficial.
Because the root is still there.
Right. The cellular machinery that produces the hair remains entirely viable right beneath the skin.
I'm looking at this 3 to 4 week recurrence cycle, and it raises a significant question for me about the long-term viability of simply plucking the hair. I mean, aside from the logistical nightmare of a patient having to visit a doctor every month just to avoid going blind, isn't there a physiological risk to repeatedly traumatizing the follicle like that?
There absolutely is. There is a highly documented rebound effect. The physical ripping of the hair shaft out of its bed induces microtrauma within the follicle itself.
And the body reacts to that trauma.
Yes. It triggers a localized inflammatory healing response, which often leads to hypervascularization of the follicle.
The body increases blood flow to the injured site.
Exactly. The follicle gets supplied with more nutrients and more oxygen, which frequently causes the next eyelash to grow back thicker, more rigid, and even more abrasive than the original one.
Oh, wow. So plucking it makes the replacement weapon even deadlier.
It does. Plus, repeated plucking can disrupt the internal orientation of the follicle sheath, causing the hair to exit at an even sharper, more damaging angle.
That's a terrible cycle.
It is. Mechanical epilation is really strictly a temporary stopgap, often used only when definitive, permanent procedures aren't available or aren't safe for that specific patient.
Okay, so to break that cycle of hypervascularized regrowth, we have to look at the methods designed for permanent eradication. The text outlines method 2, which is electroepilation.
This is where we get into the really precise stuff.
Yeah, the physics described here are intense. A hair-thin metal probe is passed down the shaft directly into the follicle, and electrical energy is delivered to destroy the root. And the text breaks this down into specific mechanisms: the galvanic method, the thermolysis method, and a blend of both.
We are moving from mechanical extraction to localized molecular destruction here.
Molecular destruction, I love that term.
The goal is to induce necrosis cell death in the stem cells of the hair bulge without causing collateral damage to the healthy eyelid tissue around it.
Let's look at the chemistry of the galvanic method first.
Yeah.
Because the text specifies that it destroys the follicle via the, quote, formation of a caustic lye.
This is a beautiful application of basic electrochemistry happening right inside human tissue.
How does it work?
Well, the metallic probe acts as an electrode. The tissue fluid inside the follicle is basically a saline environment. It contains water and sodium chloride, salt water.
Okay.
When the clinician introduces a direct electrical current, it triggers an electrolytic reaction.
The current breaks the molecular bonds of the salt water.
Yes. The reaction at the negative electrode, which is the probe, basically reorganizes the atoms. It takes the sodium, the hydrogen, and the oxygen, and it synthesizes sodium hydroxide.
Wait, sodium hydroxide, that is literally lye.
It is literally lye. You are synthesizing a potent alkaline agent directly at the cellular base of the follicle.
You are making drain cleaner inside the eyelash root.
Pretty much. The sodium hydroxide induces liquefaction necrosis, chemically dissolving the proteins of the hair matrix and the surrounding stem cells. It is a highly effective microscopic chemical burn.
That is incredible.
Yeah.
And the contrast to that is the thermolysis method, which the text describes as destroying the follicle by overheating.
Right. Where galvanic uses direct current for chemical synthesis, thermolysis utilizes high-frequency alternating current. The alternating current field rapidly oscillates the polarity of the tissue.
Because water molecules are polar, right? They have a slight positive and negative charge.
Exactly. The high-frequency field causes the water molecules in the cells to rapidly vibrate as they try to align with the shifting current.
Like rubbing your hands together really fast.
Exactly like that. This intense molecular friction generates localized thermal energy. The temperature spikes rapidly, inducing coagulation necrosis.
Leaning.
The proteins in the root just denature and cook.
Ouch. And the blend method mentioned in the text utilizes both.
Yeah. You apply the alternating current to generate heat, which dramatically accelerates the chemical synthesis of the lye from the direct current.
Best of both worlds.
It maximizes the destructive effect while minimizing the required duration of the electrical pulse, which is really vital for protecting the adjacent healthy glands in the eyelid.
Okay, so if synthesizing lye or inducing molecular friction isn't the chosen approach, the text offers method 3, cryotherapy. And it notes this is indicated for segmental trichiasis, so clusters of misdirected lashes rather than just isolated ones.
Cryo is very effective for larger problem areas.
The specific parameters outlined here are fascinating. It dictates the use of a nitrous oxide probe, using a highly precise 25-second freeze, a thaw, and then a 20-second refreeze technique.
The precision of those timing parameters really highlights the extreme cellular violence of cryosurgery. We are relying on the thermodynamic properties of sub-zero gases to shear the cells apart from the inside out.
I am looking at that specific double-cycle freeze, thaw, refreeze. Why isn't a single massive application of nitrous oxide sufficient to kill the follicle? What is the specific cellular mechanism that requires the thaw and the secondary strike?
It comes down to the dynamics of where the freezing happens. During the initial 25-second freeze, the rapid temperature drop causes ice crystals to form primarily outside the cells in the extracellular fluid.
Okay, the water outside the cell freezes first.
Right. And that draws water out of the cells via osmosis, causing them to severely dehydrate and shrink. The mechanical pressure of the ice outside, combined with the toxic concentration of salt inside the dehydrated cell, initiates significant damage.
But some of the stem cells might survive that osmotic shock.
Right, the margin for survival in a single freeze is just too high. So the crucial phase is the thaw.
What happens during the thaw?
As the tissue slowly warms, the extracellular ice melts, and the osmotic gradient reverses. Water rushes violently back into the dehydrated, compromised cells. They swell up massively.
Like overfilling a water balloon.
Exactly. And then the text mandates a 20-second refreeze. When you hit those swollen, waterlogged cells with the secondary freeze, the thermodynamics shift. Because the cells are hyperhydrated now, ice crystals form rapidly inside the cells.
Oh, wow.
These intracellular ice crystals act as microscopic shears, physically rupturing the cell membranes and destroying the mitochondria. The double cycle guarantees complete architectural failure of the follicle.
It's an incredibly aggressive manipulation of cellular thermodynamics, just blowing the cells apart with ice.
It really is.
But the text notes cryotherapy is for segments. For highly targeted destruction, it offers method 4, argon laser cilioplasty, which is recommended for just a few scattered lashes.
Here we transition from the broad, non-selective damage of freezing to the high precision of lasers, specifically selective photothermolysis.
An argon laser emits a very specific wavelength of light. How does that target the follicle without cooking the surrounding skin of the eyelid?
The argon laser wavelength is highly absorbed by melanin.
The pigment.
Right, the pigment that gives the eyelash its dark color. The surrounding skin of the eyelid margin typically has less melanin density than the hair bulb itself.
So it guards the skin.
Pretty much. When the clinician pulses the laser, the photonic energy passes relatively harmlessly through the superficial layers and is aggressively absorbed by the concentrated melanin right at the base of the follicle.
The melanin absorbs the light, converts it to heat, and vaporizes the root.
It induces explosive thermal expansion within those pigmented cells, destroying the unit with pinpoint accuracy. And this leaves the adjacent non-pigmented structures, like those critical oil glands, completely intact.
So if we step back, we have explored synthesizing localized chemical burns, inducing molecular friction, shearing cell membranes with intracellular ice, and vaporizing melanin with coherent light. The sheer magnitude of the bioengineering used just to permanently disable a tiny hair follicle is staggering.
It takes a lot of science to safely destroy a tiny piece of the human body.
It does. But the text pushes us even further. What happens when the underlying disease has warped the entire architecture of the eyelid? Lasers and probes are great for a few rogue hairs, but what about when the lid is ruined?
This is where we move from microscopic tactical strikes against individual follicles to macroscopic surgical reconstruction of the eyelid itself.
Dr. Bandyopadhyay's text outlines the interventions for severe structural failure in Section 4. For trichiasis caused by trichomatous scarring in the upper lids, the text designates specific recommended procedures: the bilamellar tarsal rotation and the transverse tarsotomy with lid margin rotation.
The biomechanical principles of these surgeries are rooted entirely in counteracting the internal pulling forces of the scar tissue we discussed earlier.
Okay, let's dissect the terminology to understand the geometry of the surgery. Bilamellar refers to the two main structural layers of the eyelid, right?
Correct. Surgically, the eyelid is divided into the anterior lamella, which is the skin and muscle, and the posterior lamella, which consists of the inner lining and the tarsal plate.
What's the tarsal plate?
It's the dense, fibrous connective tissue that provides the rigid skeletal structure of your eyelid. It gives it its shape.
Got it. And in a trachoma-scarred eyelid, that inner lining is severely shortened, creating a powerful vector pulling the lid margin inward.
Right. A bilamellar tarsal rotation seeks to break that vector.
How?
The surgeon makes a full-thickness incision horizontally right across the entire eyelid. They completely transect both lamellae, slicing right through the rigid tarsal plate.
Wait, they cut the eyelid completely in half?
Yes. This severs the eyelid margin, containing the misdirected lashes, entirely from the rest of the lid.
You completely detach the structural edge of the eyelid.
Once it's detached, the margin is physically rotated outward, typically by 180 degrees, redirecting the lash line away from the globe of the eye.
And then what? You just sew it back together?
Sutures are passed through the rigid plate, advanced through the rotated margin, and anchored in the skin, mechanically locking the margin in its new outward-facing orientation.
You are entirely dismantling the vector forces of the scar tissue and using sutures to build a new structural tension network. That is intense.
It is. And the text notes a variation: the transverse tarsotomy with lid margin rotation. A tarsotomy implies an incision directly into the tarsal plate itself.
The text also specifically lists tarsotomy for cicatricial entropion with trichiasis.
In cases where the inward pulling is severe, making a horizontal cut across the rigid plate acts as a tension-relieving incision.
Like scoring a piece of material so it bends.
Imagine a piece of stiff plastic that has been warped by a tight string on one side. If you make a horizontal score mark across the plastic, it breaks the rigidity and allows the piece to flex back toward its original shape.
Okay, I see. The tarsotomy severs the fibrotic bands, causing the distortion, allowing the front layer to pull the margin outward again.
It rebalances the mechanical tension between the anterior and posterior layers.
Now, the text then shifts to the surgical approach for distichiasis, that accessory row of mutant lashes growing out of the oil glands.
All right, the metaplasia ones.
The structural problem here isn't a curled eyelid, it's just aberrant anatomy deeply embedded in the margin. The text prescribes eyelid splitting with excision or microhyfurcation.
This procedure demands immense microsurgical precision. The surgeon must access those bad follicles without damaging the primary healthy lash line right next to them.
How do they do that?
They exploit a specific anatomical landmark called the gray line, which runs along the eyelid margin precisely between the front and back layers.
So they use a scalpel to dissect horizontally down the gray line, physically splitting the eyelid into a front half containing the normal lashes and a back half containing the oil glands hosting the rogue lashes.
Yes, you basically open the eyelid like a book.
Oh!
This exposes the deep roots of the distichiasis. Once exposed, the text mentions excision or microhyfurcation. The surgeon can manually dissect and cut out each abnormal root or use microhyfurcation, which is a form of very low-power electrosurgery, to precisely zap the rogue roots. Once the anomalous structures are destroyed, the layers are sutured back together.
We are talking about slicing a highly vascular, sensitive piece of tissue, barely 2 millimeters thick, perfectly in half.
It takes incredible skill.
The text also mentions folliculectomy for segmental trichiasis, which implies full-thickness excision of a block of lashes, and extirpation using radiosurgical techniques or cautery, which are variations of utilizing intense energy to just carve out the bad tissue.
But the absolute apex of surgical intervention detailed by Dr. Bandyopatia is the procedure reserved for severe localized structural collapse.
The last resort, the text states, full-thickness pentagonal resection with primary closure of lid, used when a segment of a lid is severely affected.
This is a definitive architectural excision. You are removing a complete vertical cross-section of the eyelid. Skin, muscle, tarsus, conjunctiva, and the entire affected lash segment. All gone.
The geometry designated here is what really catches my eye. Why a pentagonal resection? If a piece of the lid is bad, why doesn't the surgeon simply cut out a V-shaped wedge, like a triangle or a square?
It comes down to stress distribution and tissue mechanics.
Okay, explain that.
If you excise a V-shaped triangle and pull the edges together to stitch them, the maximum tension is focused exactly at the lid margin, the bottom point. This high tension will almost always cause the wound to heal with a notch.
A physical gap in the eyelid contour.
Exactly. And a notched margin fails to distribute the tear film evenly over the eye, which defeats the entire purpose of the reconstruction. You'd just be creating a new problem.
So the geometry of the cut dictates the tension of the closure.
Yes. A pentagonal excision resembles a house shape. It has straight vertical sides dropping down from the lid margin and then angling inward to a point further up the eyelid.
A pentagon.
Right. By cutting vertical parallel sides at the margin, when the surgeon brings the edges together to stitch them up, the tension vectors run horizontally, completely flat across the margin.
It prevents the margin from puckering or notching.
It creates a perfectly flush anatomical alignment. The angled cuts up at the roof of the house shape distribute the remaining tension upward into the elastic skin of the eyelid, rather than focusing it on the critical structural edge.
It's an elegant utilization of surgical geometry just to preserve the functionality of the lid.
It's engineering at its finest.
So we have journeyed from the cellular mechanics of metaplasia and chemical necrosis all the way up to the architectural geometry of pentagonal resections. We have mapped a relentless escalation of high-precision, high-technology medical interventions.
I really have.
But in the final section of Dr. Bandyopadhyay's overview, the text executes a profound shift in clinical scope. We move completely away from the operating table and the individual patient, and we zoom out to the population level.
This pivot highlights a critical reality in treating infectious diseases. You can perfectly execute the most complex bilamellar tarsal rotation, but if you do not address the macroscopic environment that generated the pathology, your surgical intervention is ultimately futile.
Right. The text places prevention at the forefront for trachoma hyperendemic areas, explicitly stating that health education is most important. It then outlines the WHO SAFE strategy for the prevention and control of the chlamydia trachomatis infection.
The SAFE strategy is a cornerstone of global public health. It's specifically designed to interrupt the transmission cycle of the bacteria before the severe scarring stages require the complex surgeries we just discussed.
The acronym breaks down the multifaceted approach. S stands for surgery for trichiasis. That encompasses the tarsal rotations and resections. A is for antibiotic treatment. F is for face washing. And E is for environmental improvement.
It covers all bases.
But looking at these 4 pillars, there is a massive conceptual friction here for me. Well, we just spent an hour dissecting the physics of intracellular ice formation and the tension vectors of pentagonal eyelid excisions. And right next to surgery, the WHO places face washing.
I see what you mean.
Isn't that a massive leap in medical complexity? How does basic hygiene share a strategic pillar with complex microsurgery?
It's a great question, but it addresses the fundamental mechanics of epidemiological transmission. The complex microsurgery only addresses the end-stage morbidity, the symptom of the scarring. The disease itself, the bacteria, relies on specific environmental vectors to spread.
Trachoma is a disease of extreme poverty and overcrowding, right?
Yes, the transmission is primarily through infected ocular and nasal secretions.
Gross, but effective.
And it is highly contagious. It is transmitted directly by contaminated hands and clothing, particularly among young children who harbor the highest bacterial loads. But a critical, highly efficient transmission vector is the Musca sorbens fly.
A fly?
Yes, an eye-seeking fly that literally breeds in exposed human feces.
Oh, wow. Okay, so the E in the strategy, environmental improvement, is directly targeting the life cycle of the vector fly.
Exactly. By improving access to clean water and constructing adequate sanitation facilities like latrines, you eliminate the breeding grounds for the fly, drastically reducing the transmission vector.
That makes perfect sense.
And the F, face washing, is equally critical. Regular washing with clean water removes the infectious discharge from the faces of children, physically removing the bacteria before it can be transmitted to a sibling or picked up by a fly.
The text also provides a very specific pharmacological mandate under the antibiotic pillar. It notes, tablet azithromycin as single dose, 1 gram, and/or topical tetracycline eye ointment twice daily for 6 weeks after surgery.
This targets the intracellular nature of the bacteria. Chlamydia trachomatis replicates inside the host's cells. A topical application of tetracycline for 6 weeks provides a sustained local bacteriostatic effect, preventing the bacteria from multiplying in the eye.
But 6 weeks of ointment is tough to keep up with.
It is, which is why the real game changer in the SAFE strategy is the single 1 gram oral dose of azithromycin.
A 1 gram dose is massive.
It is massive, and its pharmacokinetics are perfectly suited for this environment. Azithromycin has excellent tissue penetration and a very long half-life in the body.
Meaning it sticks around for a while.
Right. A single oral dose achieves high concentrations in the conjunctival tissue that persist for days, effectively clearing the systemic and localized bacterial load in a single intervention.
That's amazing.
It drastically improves patient compliance compared to a 6-week ointment regimen, which is really difficult to maintain in resource-limited settings.
But to synthesize this entire strategy, if a patient undergoes the bilamellar rotation to fix the inverted lashes, and they receive the massive blast of azithromycin to clear the active infection. If they return to a hyperendemic environment without sanitation, where flies are constantly seeking ocular discharge, and where clean water for face washing isn't available, they will simply be reinfected.
Yes, the inflammatory cascade will just reignite. The lymphocytes will return, the conjunctiva will undergo a new cycle of scarring, the internal scar tissue will contract all over again, and the perfectly executed surgical reconstruction will be slowly, inevitably pulled back inward.
The entire mechanical failure loop starts over.
Which is precisely why the text designates health education as most important. The high-tech surgical interventions are entirely dependent on the low-tech environmental interventions to last.
You cannot isolate the biology of the eyelid from the ecology of the patient's environment. The most advanced laser in the world cannot cure a disease fueled by a lack of clean water.
It's a sobering reality, but a vital one.
As we wrap up this incredibly dense deep dive to Dr. Bandyopanthe's overview, the trajectory of the information we've covered is truly staggering. We began by dissecting the acute, localized mechanical trauma of a single, misdirected keratin fiber tearing across the dense neural network of the cornea.
We examined the complex pathophysiology causing that structural failure, from the cellular metaplasia of distichiasis to the powerful pulling forces of scar contraction driven by chronic infection.
We mapped the escalating precision of the tactical strikes against the follicle, analyzing the electrochemistry of galvanic lyosynthesis, the thermodynamics of intracellular ice formation, and the photothermolysis of argon lasers.
We broke down the biomechanics of macroscopic surgical reconstruction, exploring how surgeons manipulate tension and utilize pentagonal geometry to rebuild the functional architecture of the eyelid.
And finally, we expanded our scope to the global epidemiological strategy, recognizing that all of this microscopic precision is completely reliant on the foundational public health pillars of antibiotics, face washing, and environmental sanitation.
It leaves us with a really profound realization regarding the fragility of human engineering.
It really does.
We operate daily with the assumption that our complex biology will maintain its tolerances. Yet, consider how perfectly engineered the human body is expected to be. A single hair follicle, deviating by a fraction of a millimeter in its orientation, is sufficient to initiate a slow mechanical progression toward blindness.
It's terrifying when you put it like that.
And correcting that fractional deviation requires an orchestration of localized chemical destruction, complex architectural reconstruction, massive systemic pharmacology, and massive public health infrastructure.
Just to fix one small error.
Exactly. All of this effort, all of this accumulated science is deployed simply to restore the delicate, unnoticed function of a single blink.
It is a remarkable testament to the complexity of the systems we take for granted every single day. Thank you for joining us on this deep dive.